Hi, I'm Dr. Castanet. I'm going to tell you why necks and backs hurt, how they are usually treated, why that doesn't work very well, what is a better way to treat neck and back problems, and why you should treat it this other way, and that you owe it to yourself to try this treatment if you've had frequent intermittent neck or back pain or you have chronic neck or back pain. And you'll see why it makes sense when I explain it. I'm also going to explain to you a little bit about referred pain phenomena. That is where you're likely to feel pain that arises from your neck and your low back, and so that you don't get misled. When you feel pain in your buttock, you don't imagine that it's a piriformis issue or a sacroiliac issue. Those are very uncommon entities to the extent they exist. And then when you feel pain in between your shoulder blades or in your shoulder blade, don't imagine that it's a muscular problem with your rhomboids or that you have a thoracic problem, when in fact any pain in that region is almost always coming from your neck, a neck problem. And I'll explain why, and I'll show you a chart to demonstrate referred pain patterns. These are places, referred pain patterns are places where you feel pain that makes the diagnosis counterintuitive. So if you feel pain between the shoulder blades, you're inclined to think that's where the problem is, but that's not the case. So people that are familiar with referred pain patterns, and these are mostly like neurosurgeons, orthopedic surgeons, pain management people, they're very familiar with referred pain patterns, and they seldom get tricked about where the source of the pain or the cause of the pain is coming from. It still happens even in those circumstances, but it's less common. People that are more likely to be misled about the source of the pain when pain is felt in referred areas are chiropractors and physical therapists. They just don't have the same experience with pain. They're not as familiar with the pain literature, and they're just more likely to be duped by chasing their tail about the source of the pain when it's referred away from the origin of the pain, which is a commonplace. For example, most people are familiar that if you have heart pain or pain arising from the heart, you'll typically feel it in the chest area, the sternum, but you'll also often feel it in the left arm, the left neck, the left jaw, and the left face. So people are familiar with that, but musculoskeletal sources of pain are also very commonly referred, and so I'll get into that a little bit and show you a diagram that represents those patterns of pain. In terms of why necks and backs hurt, it starts with changes to the spinal disc. Spinal discs over time wear out from the physical demands we place on them, postural demands, sitting, bending, twisting, lifting, falling, all the things we do as kids and teens that are physical and abusive. You can imagine that all the bones in our spine are connected by discs in between, and these discs serve several purposes. One is they are ligamentous structures that connect the bone to bone so that the bones stay connected, but also they're supposed to provide cushion and distribute loads. So axial loads on the spine are then distributed down to the inner part of the disc, which is a little bit like crab meat. The inner part of the disc imbibes water at night, and then so imagine it a little bit like a sponge, although the texture is more like crab meat. So it can be hydrated at night, and then in the daytime when you're upright, the axial loads then push down on this sponge or crab meat that's hydrated. It pushes out against the walls, the tough fibrous connective tissue walls of the disc, and that's how loads are distributed throughout the spine. But these discs have what we term viscoelastic properties. Some of the physical properties are viscous in nature, and some are elastic. These properties make them a little bit like rubber bands. So, for example, if I pull out a rubber band here to make my point, Imagine that this is ligamentous tissue. I can make this ligamentous tissue fail over time. Now, these are biologic tissues, so unlike the rubber band, which is inert and doesn't have any biological properties and cannot regenerate, biological tissues are in flux always, in balance between degenerative influences and regenerative influences. But to make the point in terms of the physical properties of a disc, imagine how they could fail if they're like this rubber band. I can stretch this rubber band out so far that it snaps and fails, or I can stretch it out so many cycles over a given time frame that I can make it fail and snap, or I can stretch it to some degree and hold it there for too long and make it fail. Any of those three things happens also in your low back. In terms of stretching too far, you could bend over too far, or you could move in such a way, maybe involuntarily, that causes these ligamentous tissues to stretch too far. Then they can tear. That could be a source of pain. Confoundingly, though, the inner parts of the disc fibers don't have innervation. They don't feel pain when they're injured. So injuries initially can happen in the inner part of the disc that you never perceive, and this is typically what's happening when you're a kid and you're a teenager and before you're an adult. So you acquire degenerative changes to the inner part of the disc that you don't perceive, and it's not until the outer fibers of the disc that are affected later in your life that you begin to perceive back pain associated with injuries to this ligamentous structure. So a second way that this disc can be injured is repetitive movements. So let's say you're weeding a lawn, or weeding lawn or garden, whatever, and you're repetitively bending over and stretching this. And you do this, let's say, thousands of cycles in a day. Well, by the end of the day, you're probably going to be in a good deal of pain because you have caused some microscopic failure of some of these ligamentous fibers, and this is going to be a source of pain. And lastly, the third way is you can stretch it. Let's say you're bent over for too long weeding a certain area and you're standing. So you're bent over like this for too long. Let's say you're bent over for 10, 15 minutes in one position. That can exceed the limits of these viscoelastic disc structures. That can be another source of pain. So that's what's going on. Sometimes you can recover from these because at night and because the body has reparative mechanisms, you can do some recovery. But these two things are in balance, and ligamentous tissues are not that vascular. Many parts of the ligamentous tissues are not vascular at all, and it's the blood supply that sends oxygen and nutritional substrates, the building blocks of repair. So for ligamentous tissues, they have limited potential for repair, and that's why this balance is out of balance over the course of a lifetime. And so if these are degenerative influences, these rise over the course of a lifetime. Regenerative influences don't keep pace, and so you end up with pain and disability to varying degrees because you have net degeneration of the disc and the spine as a result of this imbalance between degenerative influences and regenerative influences. We can talk a little bit about what you can do to regenerate and improve this and try to bring this up towards a proper balance between degeneration and regeneration. And we can also talk about what influencers we can do to reduce this degeneration and bring this in balance. It's very tough though, and on net, almost everybody is going to degenerate to varying degrees, but some people degenerate much, much faster so that they have significant degeneration of their spines in their 40s or 50s, and others may be able to prolong that until their 90s or 100s. So we can talk a little bit about that, but I want you to know what's going on and why necks and backs hurt. And it's because of this degeneration of the disc. When the disc degenerates, then it can't perform its normal functions properly, including acting as a cushion between the bones. The disc is hydrated. I mentioned the viscoelastic properties and the fact that what's inside is like crab meat that's hydrated, or like a sponge that's hydrated. Over time, as degeneration occurs, you lose the hydration capacity of the discs, and the discs begin to collapse, and they look smaller and thinner on x-rays and MRI scans that visualize them. When this happens, of course, and I'll use a model here now, when this happens, the bones then have more pressure on them. And if the bones have more pressure on them, they respond by getting larger. And when they get larger, the space here where the nerves run becomes smaller, because all the bone around the hole where the nerves run, all the bone here is getting larger in every dimension, every direction. So this hole becomes smaller, and then that, in addition to the soft tissue changes I've described, combine to make the space smaller and for the nerves, and then the nerves get pinched. So the nerves can be pinched acutely from, say, disc bulges and herniations, but they can also be pinched over time chronically from the changes to the bones, as well as the changes to the disc, as well as other ligamentous structures. There are other ligaments in the spinal area here, one of which is in this part right here, right behind the nerves, and this tends to bulge into this canal from this direction and enlarge and also encroach on this space. So all these changes, degenerative changes to all these tissues, combine to make this space smaller and smaller for the nerves, and if the space gets too small for the nerves, it'll start to cause pinching of several nerves. When you're younger and you have acute injuries to nerves, it's typically one side of the nerve. You get a pinching of one nerve on one side. We call that sciatica. Sciatica is simply pain in the distribution of the sciatic nerve. The sciatic nerve is made up of 5 nerve roots in the low back and the sacral area that combine in the buttock and then descend down your lower extremity and branch off to provide sensation, motor function, reflexes to the buttock, the thigh, the leg, the foot. When you get older, if this canal gets too small for the nerves, you can get what we call stenosis. Stenosis is used in 2 different ways. The first is just to describe the images on an MRI scan when we look at the holes, both this major hole, this neural canal or central canal, where all the nerves run down, and the little hole, or what we call foramen on the side here, where the nerves exit. So this hole or this hole can become narrow, and so we can use stenosis in a generic sense to describe the size of the holes and whether or not they're adequate for the nerves. But we also use stenosis to describe a clinical picture that you've seen in people that are bent over, because when this canal becomes small, the way you make the canal bigger is you bend over. And by bending over or leaning forward a little bit, you can make the canal a little bit bigger for the nerves and get some relief. So you see some older people that can't stand up straight and they're bent over chronically because they're providing more space for the nerves so that they can walk a little bit. You'll also see these people typically lean on shopping carts. And even then their capacity for walking will be limited, so they'll often have to sit down after, say, 5 or 10 minutes of walking. This can get so bad that it has to be opened up surgically and have some of the soft tissues and hard tissues removed to make space. So I don't want to get into that. But that's generally what's happening and why necks and backs hurts. It's how it proceeds. It's why it proceeds. And how are these usually treated? Well, again, let's go back to the beginning when people first start to experience back pain, and it may be acute, meaning it's recent onset, and those things are typically amenable to treatment and improvement. And sometimes it almost doesn't matter what you do. Some of these people will just take medications at home, like anti-inflammatory, and they'll get over their bout of back pain. If it's bad enough to see a provider, they're typically imaged with x-rays, maybe an MRI if there's nerve pinching going on, and then they'll be referred to a physical therapist or they may seek treatment on their own from a chiropractor. The chiropractic model of viewing this thing is not as I described. They're aware of those things happening, but by education, they're taught that it has to do with joints that are misaligned, and that the effective treatment for this is to realign joints. So typically you're treated with spinal manipulation. It may work even though the real cause is this process that I described. But if you manipulate a joint, sometimes you'll affect the process that the person will get some relief. In my experience, it is not the fastest way to treat these things effectively. It doesn't last as long, but it may last. It may work sometimes. If they're sent the physical therapy route by their medical provider, then the physical therapist will maybe do some passive modalities like electrical stim or heat or ice or ultrasound or something like that, which it can help with back pain that's probably going to be self-limited anyway and get better on its own, but it doesn't have a strong rationale for it in terms of intervening in the mechanism or this process of degeneration. You may also be given exercises for stretching, because there's often secondary muscle tightness because muscles get tight in response to pain. There are reflexes from the origin of the pain that go to the regional muscles and tell the muscles to protect the area, and muscles can do that by contracting and limiting your movement. So, and then you become aware of the tightness, and the provider is aware of the tightness, and because that's a subjective complaint on your part, and so they'll treat you with stretching, which can help with the tightness, but doesn't address the underlying initiator of the pain and the tightness. So it's not really the best, most rational, effective way to treat these things. And then they may also give you some strengthening exercises, which in my experience are highly ineffectual, if that's not an oxymoron, but very ineffectual, because they're not potent strengtheners. There is a rationale for strengthening the back over the long term, and I'll explain that too. And again, because these back problems are often self-limited, the back is very forgiving and often gets better. Sometimes even if you don't do anything, just time sometimes will make it better, that sometimes these interventions work. And again, if it's not bad, stretching can certainly help with muscle tightness, but it's not going to address this underlying process that's slowly progressive and that gives rise intermittently to back and neck pain, and sometimes to chronic back and neck pain once it gets bad enough. And it doesn't also, these treatments don't, they don't show that the person understands this underlying process. It's also partly because it seems this underlying process is slow, progressive, and like inexorable. So many treaters, providers, don't think they can intervene effectively or more effectively in this process. They think it's sort of a given for a variety of reasons, nature, nurture, genetic, environment, etc. And so the person that finally intervenes in the process in a way that addresses it directly is the surgeon, who decides at some point, okay, now we have all these degenerative changes, now we have to do something about it. We have to remove some of these tissues, and there are other things too that they often do, but it seems it's the surgeon who finally acknowledges this process that has underlied this, this eventuality, and which now requires surgery. But prior to that, it seems all these providers either don't conceive of the problem that's happening, or don't feel like there's an effective way to intervene in it, a more effective way to intervene in it. But I think it's largely just, it's not part of their conception. It's not their conceptual model of the pathophysiology of the spine, and so they don't develop more rational, effective methods to intervene in the process. So anyway, that's how it's usually treated. If the physical therapy and chiropractic don't work, then the person will be sent to pain management, where they'll do injections. Again, injections don't change anything about the anatomical process that's at play here. and causing this intermittent or chronic pain, but it can certainly provide relief for some length of time. Eventually, pain management will probably stop working, and at that point, the person will be sent to the surgeon, and the surgeon will look at the anatomy and correlate it with the person's clinical picture and decide if there's something meaningful they can do to change what they think is the anatomical source of the pain. I spent 18 years in orthopedic surgery and 5 years with a neurosurgeon, so I'm very familiar with surgical interventions also, and I know how they think, and they're fantastic people, generally. So I've explained now why the conventional treatment doesn't work. The treatment algorithm, from physical therapy or chiropractic to pain management to surgery, that's probably been your experience. And again, the non-surgical treatments sometimes fail people. Surgery can be a blessing on the right person at the right time, but we'd be doing less of it if we treated people more effectively with the non-surgical approaches. And I'll explain that in just a moment. Yeah, so the better way to treat these things is to acknowledge this process of the slow, degenerative, progressive compression of the spine. It's the compression of the disc as it degenerates, and then the bone, and then the nerves that generates pain from these three pain generators: the disc, joint, and nerve. It gives rise to pain. We know the process is compressive. That's the descriptive process. It's not a diagnosis. It's my description of all of these anatomical and physiologic changes and pathologic changes in the disc and the spine over time. They give rise on net to compression, and that causes pain. If you want to demonstrate this, just have anybody in back or neck pain carry a 100-pound weight. That will cause more pain because it causes more compression. And if they lay down, typically it relieves compression, so they'll get some relief. Well, what's even more effective than that is putting them on a decompression table. These are traction tables, but they're more sophisticated and more effective and easier for the patient and clinician to use. Pull apart the anatomy. Gently pull apart the vertebrae and unload the discs and the joints and the nerves. This, in my experience, again, spending now 35 years in practice, seeing more than 40,000 people, 18 years in orthopedics, physical medicine, and physical therapy, 5 years in a neurosurgical practice. So I think I have a pretty good idea of what's going on, and having the last 6 years treated this differently than most providers. With decompression, it's my opinion now that decompression is a more rational and definitely more effective, by a large margin, treatment for most people with neck and back pain. It ought to be the first fundamental approach to treating neck and back pain, with some ancillary things as well, like stretching and strengthening and stuff like that. I do want to touch in a moment on the strengthening component, but in terms of decompression, in my experience, it works faster. Put them on a table, you pull this part of the anatomy apart. It lasts about a half hour. It's gentle. It's reasonably comfortable. Most people don't feel pain on the treatment. Occasionally people get some symptoms during the course of the treatment, but it's never bad enough to cause the end of treatment. Typically they'll feel pain either right away or the next day, and the pain will usually subside as follows. You'll do a course of treatments. Very rarely it'll be one treatment and the person will be out of pain, but that's very rare. Also rarely it'll take 20 treatments and the person will be out of pain. More typically it'll be something in between. They'll generally be getting, during the course of their treatments, they'll get more and more good time and less bad time. And that's generally how people will improve. Again, it could be anywhere between 0 and 20 treatments, and very, very rarely it'll be more than that. Occasionally for people with significant, long-standing, chronic degeneration and back pain, they'll need to do this treatment intermittently the rest of their lives. That's just the nature of the beast. It's that or surgery, and sometimes surgery is indicated, sometimes it's not. Surgeons don't want to do surgery when they don't feel like the patient will be significantly better off from the surgery. There are risks entailed in surgery. Again, in the right patient at the right time, surgery is a godsend. Like anything, it's about correlating or marrying the right problem in a patient with the right treatment. It's just my experience that the decompression treatment is by far more effective than physical therapy and chiropractic approaches to treatment of neck and back problems. If you've had intermittent recurring back or neck pain and you've been back and forth with a chiropractor or physical therapist, or you don't feel like you get that better, that fast, or well enough, you owe it to yourself to do the decompression as means of treatment. When I see patients, they very often have been elsewhere. 80% of the time, the first treatment, they'll get relief, sometimes a little, sometimes a lot. But that's pretty good for a first treatment, 80%. And again, they'll get better faster and stay better longer for this problem. There's another problem that can arise for people with chronic intermittent back pain, and that is that because they will use their back less frequently during the course of the day, over years, what happens is the muscles in the low back will atrophy. They'll get weak, they'll get smaller, and instead the area where the low back muscles were will become occupied or infiltrated with fatty tissue. That is reversible, and now surgeons have implanted devices because non-surgical providers have done a poor job at getting patients to strengthen their backs. They've implanted electrodes into the spine, into those muscles to get those muscles to contract. Then they program the patient to do this twice daily for half hour at a time. And again, these electrodes are effective at reducing pain over the next several years. And I can't think of another intervention in back treatment and neck treatment, well, this is just for the low back, that actually makes a person's pain less over time than the usual changes that occur as we age, where back pain typically gets worse over time. That's a generality. It's not always true, but anyway. So we know strengthening the muscles is effective because when you make it effortless for patients to do it, and you program it, and you put electrodes in the muscles, and the muscles do it, well, then people get better because they can't avoid exercise. So we know it's effective. And we also know generally volitional exercise is more effective than passive means of exercise, because we've had electrodes forever. I mean, for many, many years, decades. You can put passively electrodes over your back muscles, and you could do this theoretically using a machine, but that's not as effective as doing it on your own, and you wouldn't have to do it as much. But this is why bodybuilders and weightlifters and powerlifters don't use electronic devices to get big muscles and get strong. They use weights, because volitional effort on your part much more effective than the passive means of contracting these muscles. But as a proof of concept, it had tremendous value that surgeons finally did this for the population of people that won't do anything in the way of exercise. But it's also a failing that reflects a failing on the part of chiropractors and physical therapists and non-surgical providers, because we have not really provided effective exercises, and maybe we're not even committed to the idea. Maybe we didn't know how effective it can be for people to get stronger back muscles. So that's something I've addressed on other videos. I show you the machines. You can find videos on this on my YouTube channel, Dr. Castanet. And so that's the way it should be treated, with decompression, and then preventive going forward. Strengthening should be part of your back treatment. That means every day, one set of exercises is probably sufficient on a Roman chair or perhaps deadlifting, but every day on a regular basis. And over time, your back pain should get better and better and better. So I hope I've explained this to you in a way that you find logical, and that now you know another alternative if you're having recurring back or neck pain or chronic pain that's not helped with the physical therapy and chiropractic approaches that are conventional, I think you owe it to yourself to try this. If you are having these problems, and if I can help, I'm Dr. Castanet in Decatur, Georgia. My number is 404-558-4015. The website is backstrong.net, and my YouTube channel is Dr. Castanet. Thanks very much. Bye-bye.